Welcome to this comprehensive lecture on sickle cell disease presented by Pediatric Case Review. This advanced clinical overview is designed specifically for healthcare professionals seeking to deepen their understanding of this complex hematologic disorder. Throughout this presentation, we will explore the genetic basis, pathophysiology, clinical manifestations, diagnostic approaches, management strategies, and recent advances in the field. Our goal is to provide you with evidence-based knowledge that will enhance your clinical practice and improve patient outcomes. Let us begin this educational journey into the world of sickle cell disease. Which of the following statements about the genetics of sickle cell disease is correct? Option A, it follows an autosomal dominant inheritance pattern. Option B, it results from a point mutation in the alpha globin gene. Option C, it follows an autosomal recessive inheritance pattern with HBS mutation at position 6. Option D, it requires mutations in both alpha and beta globin chains. Consider the inheritance pattern, specific gene involved, and molecular basis of this condition as you formulate your answer. The correct answer is C. Sickle cell disease follows an autosomal recessive inheritance pattern with a hemoglobin S mutation at position 6. This condition results from a point mutation where guanine-adenine-guanine changes to guanine-thymine-guanine, causing substitution of glutamic acid with valine at the 6th position of the beta globin chain. Homozygous hemoglobin SS causes classic sickle cell anemia. Compound heterozygous states include hemoglobin SC and hemoglobin S beta thalassemia. The mutation specifically affects the beta globin gene, not the alpha globin gene, making options A, B, and D incorrect. Which factor does not trigger or exacerbate sickling in patients with sickle cell disease? Option A, dehydration. Option B, infection. Option C, alkalosis. Option D, hypoxemia. Consider the pathophysiology of hemoglobin S polymerization and how various physiological conditions affect the sickling process. Think about the oxygen dissociation curve and how pH changes impact hemoglobin behavior. The correct answer is C. Alkalosis does not trigger or exacerbate sickling in patients with sickle cell disease. In fact, acidosis, not alkalosis, promotes sickling by decreasing hemoglobin's oxygen affinity. Dehydration increases intracellular hemoglobin concentration, promoting polymerization. Infection increases metabolic demands and inflammatory mediators that can trigger sickling. Hypoxemia directly triggers hemoglobin S polymerization and sickling. Alkalosis actually inhibits sickling by increasing hemoglobin's oxygen affinity, shifting the oxygen dissociation curve to the left, which is why sodium bicarbonate has been historically used in acute sickle cell crises. A 6-month-old infant of Afro-Caribbean ethnicity is discovered to have sickle cell disease through newborn screening for hemoglobinopathies. Which statement is true? Option A, carrier frequency is approximately 1% in this population. Option B, the condition offers protection against malaria. Option C, the child likely has hemoglobin SC disease. Option D, the condition is most common in Northern European populations. Consider the epidemiological patterns, genetic inheritance, and evolutionary advantages associated with sickle cell disease in different populations. The correct answer is B. The condition offers protection against malaria. The heterozygous state for sickle cell disease provides a selective advantage against falciparum malaria, explaining the high frequency of the sickle cell gene in malaria endemic regions. Carrier frequency is 8 to 10% in Afro-Caribbean populations, not 1% as stated in option A. Without additional information, we cannot assume the child has hemoglobin SC disease as stated in option C. Hemoglobin SS is more common. The condition is not most common in Northern European populations as stated in option D. It has the highest prevalence in sub-Saharan Africa, Mediterranean, Middle East, and parts of India. Newborn screening identifies the disease before symptoms develop, allowing for early intervention. Which physical examination finding is least likely in a 6-year-old with sickle cell disease? Option A, hepatomegaly. Option B, jaundice. Option C, splenomegaly. Option D, growth retardation. Consider the typical clinical manifestations of sickle cell disease and how they evolve with age, particularly focusing on the natural history of splenic involvement in children with this condition. The correct answer is C. Splenomegaly is the least likely finding in a 6-year-old with sickle cell disease. Functional asplenia typically occurs by age 1 and anatomical autosplenectomy by age 5 due to repeated infarction and fibrosis of the spleen. Splenomegaly in children older than 5 years suggests an alternate diagnosis or complications such as hemoglobin SC disease, sickle beta thalassemia, or splenic sequestration crisis. Hepatomegaly, jaundice, and growth retardation are common findings in sickle cell disease due to chronic hemolysis, extramedullary hematopoiesis, and chronic anemia. General examination findings may include small for age, pallor, jaundice, and multiple cannulation scars from previous hospitalizations and treatments. A 10-year-old with sickle cell disease presents with severe bone pain after swimming in cold water. What is the first-line management? Option A, exchange transfusion. Option B, hydroxyurea initiation. Option C, aggressive hydration, warmth, analgesia. Option D, prophylactic antibiotics only. Consider the typical triggers for vaso-occlusive crisis and the stepwise approach to managing acute painful episodes in sickle cell disease. The correct answer is C. Aggressive hydration, warmth, and analgesia constitute the first-line management for this vaso-occlusive crisis. Initial management includes hospital admission, intravenous fluids to maintain hydration, warming the patient to reverse cold-induced vasoconstriction, oxygenation if hypoxemic, and appropriate analgesia. Cold exposure triggers sickling through peripheral vasoconstriction and decreased circulation. Exchange transfusion is reserved for severe complications such as stroke, acute chest syndrome, or priapism, not for routine painful crises. Hydroxyurea is a chronic therapy, not an acute intervention. Antibiotics are indicated only if infection is suspected or confirmed. Acute painful crisis can be triggered by cold exposure, infection, and dehydration. Which laboratory finding is diagnostic of homozygous sickle cell disease, hemoglobin SS? Option A, hemoglobin A 45%, hemoglobin S 45%, hemoglobin F 5%, hemoglobin A 2 5%. Option B, hemoglobin A 0%, hemoglobin S 90%, hemoglobin F 8 to 10%, hemoglobin A2 2%. Option C, hemoglobin A 60%, hemoglobin S 30%, hemoglobin F 8%, hemoglobin A2 2%. Option D, hemoglobin A 95%, hemoglobin S 0%, hemoglobin F 3%, hemoglobin A2 2%. Consider the typical hemoglobin electrophoresis patterns in different sickle cell variants and normal individuals. The correct answer is B. The pattern showing hemoglobin A 0%, hemoglobin S 90%, hemoglobin F 8 to 10%, hemoglobin A2 2% is diagnostic of homozygous sickle cell disease. This pattern demonstrates the absence of normal adult hemoglobin A with predominant hemoglobin S. Pattern A represents sickle cell trait, which is the heterozygous state. Pattern C suggests hemoglobin SC disease or another variant. Pattern D represents the normal adult hemoglobin pattern. Hemoglobin electrophoresis is the diagnostic test that reveals these characteristic patterns. Additional laboratory findings in sickle cell disease include normocytic normochromic anemia with reticulocytosis and blood film showing anisocytosis, poikilocytosis, and sickle cells. A 7-year-old with sickle cell disease presents with fever, chest pain, cough, and hypoxemia. What is the most appropriate management? Option A, oral antibiotics and discharge home. Option B, intensive care unit admission, oxygen, hydration, antibiotics, exchange transfusion. Option C, standard vaso-occlusive crisis protocol only. Option D, immediate splenectomy. Consider the severity of acute chest syndrome and the appropriate intensive management approach for this life-threatening complication of sickle cell disease. The correct answer is B. The most appropriate management for this child with acute chest syndrome is intensive care unit admission with oxygen therapy, hydration, antibiotics, and exchange transfusion. Acute chest syndrome is a life-threatening complication that requires intensive care management. Empiric antibiotics should cover atypical organisms, typically macrolides plus ceftriaxone. Exchange transfusion is indicated for severe hypoxemia or clinical deterioration. The mortality rate for acute chest syndrome is 4 to 9%, particularly high in adults or those with comorbidities. This condition presents with severe chest pain, fever, cough, and often a history of previous hospitalizations. Standard vaso-occlusive crisis protocol alone is insufficient for acute chest syndrome, and immediate splenectomy is not indicated for this pulmonary complication. Which of the following is true regarding splenic sequestration crisis in sickle cell disease? Option A, it typically occurs after age 5. Option B, it presents with hypertension and abdominal discomfort. Option C, it requires urgent blood transfusion. Option D, it is associated with elevated hemoglobin levels. Consider the typical presentation, age of occurrence, and emergency management of this potentially fatal complication of sickle cell disease. The correct answer is C. Splenic sequestration crisis requires urgent blood transfusion. This life-threatening complication typically occurs before age 5, before complete autosplenectomy. It presents with acute splenic enlargement, abdominal pain, hypotension, not hypertension as stated in option B, and circulatory collapse. The condition is associated with profound anemia and shock requiring urgent transfusion, not elevated hemoglobin levels as stated in option D. The recurrence rate is up to 50%, and splenectomy may be required after recovery from a second episode. Splenic sequestration crisis is a medical emergency that needs immediate life-saving blood transfusion to prevent fatal outcomes from hypovolemic shock and severe anemia. A 5-year-old with sickle cell disease develops sudden hemiplegia. Neuroimaging confirms stroke. What is the appropriate long-term management? Option A, aspirin therapy alone. Option B, chronic exchange transfusions to maintain hemoglobin S less than 30%. Option C, hydroxyurea alone. Option D, observation only. Consider the high risk of stroke recurrence in sickle cell disease and the most effective preventive strategies based on current evidence and guidelines. The correct answer is B. Chronic exchange transfusions to maintain hemoglobin S less than 30% is the appropriate long-term management for this child with stroke. Without intervention, the stroke recurrence rate is greater than 60%. A chronic transfusion program reduces recurrence to less than 10%. Transcranial Doppler screening after age 2 identifies high-risk patients with velocities greater than 200 centimeters per second, which is an indication for exchange transfusion. Physiotherapy and rehabilitation are essential components of management. Aspirin therapy alone, hydroxyurea alone, or observation only are insufficient for preventing stroke recurrence in this high-risk population. Neurological complications in sickle cell disease include stroke with hemiplegia and cranial nerve affection requiring aggressive preventive management, which is not an indication for hydroxyurea therapy in sickle cell disease. Option A, frequent painful episodes, 3 or more per year. Option B, history of acute chest syndrome. Option C, isolated mild anemia. Option D, recurrent priapism. Consider the established indications for hydroxyurea therapy based on clinical evidence and guidelines, focusing on which conditions warrant this disease-modifying treatment. The correct answer is C. Isolated mild anemia is not an indication for hydroxyurea therapy in sickle cell disease. Hydroxyurea increases hemoglobin F production with a goal of greater than 30%. It is indicated for frequent painful crises, 3 or more per year, history of acute chest syndrome, and severe vaso-occlusive events including recurrent priapism. Treatment can start from 9 months to 2 years of age in appropriate candidates. Hydroxyurea requires regular monitoring for myelosuppression and other side effects. It is the only effective drug proven to reduce the frequency of painful episodes. Isolated mild anemia is a common feature of sickle cell disease that does not by itself warrant hydroxyurea therapy, as the medication is reserved for more severe manifestations of the disease. A 14-month-old with sickle cell disease has functional asplenia. Which intervention is most important for preventing life-threatening infections? Option A, annual influenza vaccination. Option B, lifelong penicillin prophylaxis. Option C, monthly intravenous immunoglobulin infusions. Option D, quarterly complete blood count monitoring. Consider the most effective preventive strategy for overwhelming infection due to encapsulated organisms in children with sickle cell disease who have developed functional asplenia. The correct answer is B. Lifelong penicillin prophylaxis is the most important intervention for preventing life-threatening infections in this child with functional asplenia. Functional asplenia develops by age 1 in sickle cell disease, significantly increasing the risk for infections with encapsulated organisms. Penicillin prophylaxis reduces pneumococcal sepsis risk by more than 80%. Additional preventive measures include a complete immunization schedule with pneumococcal, meningococcal, and Haemophilus influenza vaccines. Prompt evaluation of fever, 38.5 degrees Celsius or higher, with cultures and empiric antibiotics is essential. While annual influenza vaccination is important, it is not as critical as penicillin prophylaxis. Monthly intravenous immunoglobulin infusions and quarterly complete blood count monitoring are not standard preventive measures for infection in this context. Which condition does not typically require exchange transfusion in sickle cell disease? Option A, acute chest syndrome. Option B, stroke. Option C, priapism. Option D, aplastic crisis. Consider the different types of transfusion approaches, simple versus exchange, and their specific indications for various complications of sickle cell disease. The correct answer is D. Aplastic crisis does not typically require exchange transfusion in sickle cell disease. Aplastic crisis, often caused by parvovirus B19 infection, requires simple transfusion to address the profound anemia, not exchange transfusion. Exchange transfusion is indicated for acute chest syndrome, stroke, and priapism. The goal of exchange transfusion is to reduce hemoglobin S percentage while avoiding hyperviscosity. Complications of transfusion therapy include alloimmunization, ion overload, and transfusion reactions. Blood transfusion, simple, is indicated for sequestration crisis and aplastic crisis, while exchange transfusion is reserved for more severe complications like priapism, acute chest syndrome, and stroke. Understanding the appropriate transfusion approach for each complication is crucial for optimal management of sickle cell disease. A 12-year-old with sickle cell disease presents with progressive right hip pain and limited range of motion. What is the most likely diagnosis? Option A, septic arthritis. Option B, avascular necrosis of femoral head. Option C, slipped upper femoral epiphysis. Option D, osteomyelitis. Consider the common musculoskeletal complications of sickle cell disease and their typical presentations, particularly focusing on hip pathology in adolescents with this condition. The correct answer is B. Avascular necrosis of femoral head is the most likely diagnosis in this 12-year-old with progressive hip pain and limited range of motion. This is a common complication of sickle cell disease due to vaso-occlusion of the vessels supplying the femoral head. Hip radiographs and magnetic resonance imaging confirm the diagnosis. Management includes analgesia, physical therapy, core decompression, and eventually arthroplasty in severe cases. Other musculoskeletal complications of sickle cell disease include dactylitis, hand-foot syndrome, leg ulcers, osteomyelitis, and slipped upper femoral epiphysis. While septic arthritis, slipped upper femoral epiphysis, and osteomyelitis can occur in sickle cell disease, the progressive nature of the symptoms and the age of the patient make avascular necrosis the most likely diagnosis in this clinical scenario. Which renal manifestation is least common in sickle cell disease? Option A, hematuria. Option B, hyposthenuria. Option C, nephrotic syndrome. Option D, papillary necrosis. Consider the spectrum of renal complications in sickle cell disease and their relative frequencies, focusing on which manifestation is least frequently observed in this population. The correct answer is C. Nephrotic syndrome is the least common renal manifestation in sickle cell disease. Sickle cell nephropathy typically presents with microalbuminuria progressing to proteinuria, but full nephrotic syndrome is relatively uncommon. Hyposthenuria, the inability to concentrate urine, occurs early due to medullary infarctions and is very common. Hematuria is common and results from papillary necrosis or renal infarction. Papillary necrosis itself is also a frequent complication. Progressive renal disease affects 4 to 18% of patients and can lead to chronic kidney disease. While proteinuria occurs in sickle cell nephropathy, it rarely reaches nephrotic range levels. Renal function should be monitored regularly with urea and electrolytes and creatinine measurements to detect sickle cell nephropathy and chronic kidney disease early. A 25-year-old with sickle cell disease reports blurred vision. Fundoscopic examination shows retinal neovascularization. What is the most appropriate next step? Option A, observation only. Option B, urgent laser photocoagulation. Option C, intravitreal steroids. Option D, exchange transfusion alone. Consider the management of proliferative sickle retinopathy and the most effective intervention to prevent vision loss in this condition. The correct answer is B. Urgent laser photocoagulation is the most appropriate next step for this patient with proliferative retinopathy. Proliferative sickle retinopathy requires prompt intervention to prevent vision loss. The pathophysiology involves retinal ischemia leading to neovascularization, which can cause serious complications if left untreated. Laser photocoagulation is the treatment of choice to ablate these abnormal blood vessels and prevent vitreous hemorrhage and retinal detachment. Regular ophthalmologic screening is essential from adolescence to detect retinopathy early. Observation alone would risk progression to vision-threatening complications. Intravitreal steroids are not the primary treatment for proliferative sickle retinopathy. While exchange transfusion may be considered in some cases, it is not the definitive treatment for established proliferative retinopathy with neovascularization. Ophthalmologic complications in sickle cell disease include proliferative retinopathy that can progress to blindness if not properly managed, which is not a common cause of abdominal pain in patients with sickle cell disease. Option A, splenic sequestration crisis. Option B, cholelithiasis. Option C, intussusception. Option D, vaso-occlusive crisis. Consider the various etiologies of abdominal pain in sickle cell disease and distinguish between those directly related to the pathophysiology of the disease versus those that are not typically associated with it. The correct answer is C. Intussusception is not a common cause of abdominal pain in patients with sickle cell disease. Common causes include vaso-occlusive crisis, cholelithiasis, and splenic sequestration. Other etiologies include hepatic sequestration, nonsteroidal anti-inflammatory drug gastritis, and lower lobe pneumonia that can present with abdominal pain. Pigment gallstones occur in more than 50% of patients by adulthood due to chronic hemolysis. Abdominal evaluation is essential to differentiate surgical emergencies from vaso-occlusive crisis. Intussusception, while it can occur in any child, is not specifically associated with sickle cell disease and is not among the common causes of abdominal pain in this population. When evaluating abdominal pain in sickle cell disease, clinicians must consider both sickle-related causes and other potential etiologies, but intussusception would not be high on the differential diagnosis list. A 28-year-old woman with sickle cell disease is 10 weeks pregnant. Which management strategy is CONTRA and ECTD during pregnancy? Option A, folic acid supplementation. Option B, continuation of hydroxyurea. Option C, exchange transfusion for complications. Option D, prophylactic antibiotics. Consider the safety of various sickle cell disease treatments during pregnancy and which interventions should be avoided due to potential fetal harm. The correct answer is B. Continuation of hydroxyurea is contraindicated during pregnancy. Hydroxyurea is teratogenic and must be discontinued before conception and throughout pregnancy. Pregnancy in women with sickle cell disease carries increased maternal fetal risks, including preeclampsia, preterm delivery, and intrauterine growth restriction. Management requires a multidisciplinary approach with increased folic acid, 5 mg daily, continuation of prophylactic antibiotics, and close monitoring. Exchange transfusion may be considered for severe complications or patients with a prior history of serious sickle-related events. Folic acid supplementation is actually recommended at higher doses during pregnancy in sickle cell disease. Prophylactic antibiotics should be continued due to the ongoing risk of infection with functional asplenia. Exchange transfusion can be safely performed when indicated for severe complications during pregnancy. Which statement about hematopoietic stem cell transplantation in sickle cell disease is correct? Option A. It is indicated for all patients regardless of severity. Option B. It has greater than 95% success rate with minimal complications. Option C. It is currently the only curative treatment. Option D. It is contraindicated in patients with prior stroke. Consider the current role, indications, outcomes, and limitations of hematopoietic stem cell transplantation as a treatment option for sickle cell disease. The correct answer is C. Hematopoietic stem cell transplantation is currently the only curative treatment for sickle cell disease. It is indicated for severe disease manifestations, including stroke, recurrent acute chest syndrome, and refractory pain, not for all patients regardless of severity as stated in option A. While overall survival is greater than 90% with matched sibling donors, the success rate is not greater than 95% with minimal complications as stated in option B. Complications include graft failure, graft versus host disease, infertility, and infections. Contrary to option D, hematopoietic stem cell transplantation is not contraindicated in patients with prior stroke. In fact, stroke is one of the indications for transplantation. Human leukocyte antigen-matched sibling donor is optimal, but alternative donor sources are emerging. Hematopoietic stem cell transplantation represents the definitive treatment for sickle cell disease when an appropriate donor is available. A 20-year-old with frequent vaso-occlusive crises despite maximal hydroxyurea is considering new therapies. Which recent Food and Drug Administration approved option targets P-selectin? Option A, voxelotor. Option B, crizanlizumab. Option C, L-glutamine. Option D, gene therapy. Consider the mechanisms of action of newly approved therapies for sickle cell disease and identify which one specifically targets P-selectin to reduce vaso-occlusion. The correct answer is B. Crizanlizumab is the recent Food and Drug Administration approved option that targets P-selectin. It is an anti-P-selectin monoclonal antibody that reduces cell adhesion and decreases the frequency of vaso-occlusive crises. Voxelotor works by increasing hemoglobin oxygen affinity, reducing sickling, but does not target P-selectin. L-glutamine reduces oxidative stress in sickle erythrocytes through a different mechanism. Gene therapy approaches show promise for potentially curing sickle cell disease but remain investigational and are not yet widely available. The development of these novel therapies represents significant progress in sickle cell disease management, offering options for patients who continue to have frequent vaso-occlusive crises despite maximal hydroxyurea therapy. Each of these agents targets different pathophysiological mechanisms of the disease. Which specialist is typically not part of the core multidisciplinary team for sickle cell disease management? Option A, hematologist. Option B, dermatologist. Option C, neurologist. Option D, nephrologist. Consider the various organ systems affected by sickle cell disease and the specialists typically involved in comprehensive care, distinguishing between core team members and those consulted only for specific complications. The correct answer is B. A dermatologist is typically not part of the core multidisciplinary team for sickle cell disease management. The core team includes a hematologist, primary care physician, pain specialist, neurologist, and ophthalmologist. The extended team may include an orthopedist, nephrologist, pulmonologist, and cardiologist depending on specific complications. Psychosocial support with social workers and psychologists is essential for chronic disease management. A school liaison is important for academic accommodations. While dermatologists may be consulted for leg ulcers, a common complication of sickle cell disease, they are not typically considered core team members. The multidisciplinary approach for sickle cell disease involves specialists who manage the most common and serious complications of the disease affecting various organ systems. Dermatologic consultation is reserved for specific skin-related issues rather than being part of the routine care team. Thank you for watching this comprehensive lecture on sickle cell disease presented by Pediatric Case Review. We have explored the genetic basis, pathophysiology, clinical manifestations, diagnostic approaches, management strategies, and recent advances in this complex hematologic disorder. Remember that sickle cell disease requires a comprehensive understanding of its pathophysiology and manifestations for optimal patient care. Early intervention and preventive strategies significantly improve outcomes, and a multidisciplinary approach is essential for optimal management. Please follow our channel for more informative presentations and feel free to comment with any questions you may have. We value your feedback and engagement as we continue to provide educational content for healthcare professionals.